Thank you so much. Good morning, everyone. I'm very grateful to Professor Bhavna and AIOC for giving me the opportunity to present in this session. So I'm going to cover contact lens associated ocular emergencies and complications. Basically, when you look at the contact lens evidence-based academic report of 2021, though contact lenses were invented as long ago as 1887, over the years there's been a revolutionary change in the type of material and the usage of contact lenses. And when we're looking from the optometrist or the practitioner's point of view, it's very important that when you're dealing with a contact lens practice, you must engage the people who are dispensing the lenses, because as ophthalmologists, we're totally very well equipped. But contact lenses is something which even in the previous session, the speakers had mentioned, many people take it very lightly. They take it like a cosmetic product, and often non-professionals are handling the dispensing and the patients are not being properly educated. So one has to simplify this knowledge, and you have to sort of empower the patient to know about what to expect when they start wearing contact lenses. So basically, one could look at the location, the etiology, and the severity of whatever the problems are. And when you look at contact lens associated ocular emergencies, they may not look that terrible as compared to the really true emergencies that we see in ophthalmology. But here I want to specify that with a contact lens, when a person is out in the periphery or out in the public and is not under proper care, then the emergency has a different context. Like even the presence of an epithelial defect or a small dryness and a weak spot in the epithelium, that can lead to devastating effects. And generally, a large number of patients actually do have a red or painful eye requiring emergency eye care, which is quite a lot when you consider the total number of contact lens wearers. And what would you take as a red flag for a situation which may escalate into a true emergency is a reduction in wear time, discontinuation from wear, need to seek emergency eye care. Similarly, we do know that there are well-defined anatomical and physiological effects on the ocular surface as a result of contact lenses. And young people with refractive errors who are wearing contact lenses earlier, when refractive surgery was more complicated, often contact lenses would be a go-to option. But now refractive surgery having become so safe, often the contact lens wear is more dangerous in certain situations if the patient is not going to be careful. Because even 43% of asymptomatic wearers were actually found on review to have clinically observed ocular surface signs. And you can imagine what would be the devastating effect if a young person develops a central keratitis. So the components responsible for complications, they are of course physical and physiological factors. They could be wearer related, because often patients may sleep with the contact lens, they may not be that careful with the hygiene. And this is another thing you need to take into account when you're counseling a patient whether to wear a contact lens or not. And then there are some patients who actually require the contact lens actually for their vision, where they don't have any other options, such as keratoconus or pellucid marginal degeneration, which are not amenable to surgery. And then there are, of course, pathological factors. So the checkpoints, one would like to look at the compliance and compatibility. And if a patient comes with an emergency, you have one point of time then to look into what are the weaknesses in the use of the lenses, the material design, etc. And you can take corrective measures at that point. The most dreaded complication, of course, is microbial keratitis. You can also have sterile keratitis. There can be metabolic effects and mechanical effects. And you can also have toxic and allergic disorders. Sometimes patients will not understand the instructions. There was a lady who came recently who was putting the contact lens solution inside the soft contact lens and then putting the contact lens onto her eye because she felt her eye was dry and maybe that would help. So there could be tear resurfacing disorders, dry eye, and contact lens discomfort. Now, contact lens related complications, there is a review of a whole lot, but as we know, bacterial acanthamoeba and fungal keratitis are the most severe, and as ophthalmologists, we all know how to treat them. If I have a patient with contact lens induced keratitis, I would definitely scrape the ulcer and also send the contact lens, the solution, and the case for culture, even if it doesn't help to know what is the actual organism, but you get an idea about the hygiene. As often the patients, of course, have thrown away the contact lens, but you can send a specimen from the case as well as the solution and the tip of the bottle, which is the dispensing the solution. We can have corneal staining and corneal edema, which may not look like an emergency from a sort of true emergency point of view, but for a contact lens wearer, it is actually an emergency, and for the practitioner who detects it, because if you don't take care of the problem at that time, you may end up with a more devastating problem. So here are a few case studies. This is a patient who's been wearing RGP contact lenses for keratoconus for more than 5 years, and it was a flat-fitting lens with apical staining marks. There was discomfort and unstable vision. So observation on removing the lens showed that there were ring marks, there was poor tear exchange, and there was staining because of lens touch. So poor fit, this can lead to corneal edema, corneal staining, and this can then lead to an escalation or a cascading effect of a keratitis. So it's very important to examine the patient carefully, and also it's important to make the patient wear the lens and reassess after half an hour or 45 minutes to see what is the effect before you send the patient home. You can have staining on the cornea post-contact lens removal. So this is again something which needs to be taken care of. And as you can understand, for a patient with keratoconus who is really dependent on that lens for vision, so just removing that contact lens and saying you have to manage with spectacles is like a complete change in what they can do and how they can live their life for the next day or two. So this is very important to intervene early. There can be contact lens deposits, there could be poor care and regimen, and progressive keratoconus. This is another example of a patient who was prescribed the Rose K2 lens, and you can see there are staining ring marks and lens impression on the cornea post-contact lens removal. And then after fitting again, one should reevaluate after 60 minutes and then remove the lens again. Only then will you see these contact lens compression rings, which will indicate that actually the fit is not perfect. This is an example of a post-C3R patient fitted with scleral lenses. Even with scleral lenses, always look carefully when they come in wearing the lens to look at the tear film debris or the lake which is present to make sure that there are no debris or there is no trapment. Altered tear film after using a conventional soft contact lens for long hours can also be there. Generally, it's very important to caution the patient, but many times the patient will be wearing the contact lens for 10 to 12 hours and sometimes even sleep with the contact lens, which is definitely a dangerous problem. Regarding complications of scleral lenses, now this is very daunting and it's very difficult for the patient to learn how to wear the lenses, and it requires a lot of chair time. You can have application bubble, difficulty with lens removal, non-wetting, surface deposits, corneal bogging, scarring, inflammation, and solution sensitivities. And of course, there are fitting challenges. You must see if there is any nipping of the vessels at the end, which are showing that there are tight edges, and there's an impression ring after removing the contact lens. So when you fit it, let the patient wait for half an hour, 45 minutes, or an hour, and then reassess afterwards. There could be apical bearing, there could be impingement and blanching of the vessels in the periphery, indicating that it is too tight. It could be sagging as well, and there could be conjunctival or limbal redness as a result of the poor fit. There could be a stuck scleral lens, which can be quite a sort of very panicky situation for the patient. There could be reduced tear vault. There could be deposits over the contact lens surface. There could be also solution toxicity, and the patient can come with a very red eye. There could be hypoxia with neovascularization, and this is an example of a 30-year-old female with pellucid marginal degeneration wearing a large diameter scleral contact lens for 10 months. She complained of stinging after lens removal, photophobia, frequent blurring of vision, and slight discomfort post-lens removal. On a detailed ocular surface examination, it was found that she had a poor tear film, she had a high OSDI score, and the wear time was approximately 17 to 18 hours, which tends to happen in these patients because they're totally dependent upon that contact lens for their vision and daily care. On slit lamp examination, you could see inferior steepening. There could be well-fitted scleral contact lens on an irregular cornea. There could be irregularity of the tear film, scratches on the lens surface. And these lenses being expensive, often the patients are not able to, they try to avoid having to change them. Thick layer of deposits can be there, and staining of the contact lens post-removal. So the treatment, patient was advised to stop the scleral lens for a week. So it's very important to have a rehabilitative alternative pair of spectacles as an alternative, and then you would prescribe lubricants and review after 3 to 4 weeks. Post-treatment follow-up, there was a remarkable improvement, and the patient was going to go back, and you require to give them a lot of psychological support because they get quite devastated with the concept that now they cannot use their contact lenses and will not be able to, say, go to work or do whatever their daily routine is. Deposits and care, you can see patients of severe keratoconus, how they do well with a well-fitted contact lens, but you can have lipid deposits, so that they do require periodic professional cleaning. We can have a protruding close, poor stability, refitting can be done, and you can also advise reusable moist heat masks with complete usage instructions. And one can sometimes give us antibiotic eye drops for 10 days, and sometimes steroids may be required as well. So in this, to control the inflammation, because we have shown that just having the contact lens on the surface is, after all, a foreign body, and it does produce changes in the meibomian glands. That's another total different discussion, and we have a paper on that. But this is indicated to always be aware that even contact lens wearers do have MGD, and they do have an ocular surface instability, and they can be complaining of stinging or sensations, and often they do not, they're not very particular about being regular with their lubricant eye drops. So a well-fitted scleral lens, look at the edge, and OCT is a very good tool to assist you with the process. We have a patient of post-RK ectasia who came for the first follow-up prescription. There was conjunctival blanching due to tight contact lens edges and indentation, and the scleral bowl was not properly fitted with saline. After all this was addressed, the patient was comfortable and was able to continue with normal life. So the tips to care: regular follow-up, early presentation, avoidance of overnight wear, reminder cues to the patient, and so consider changing materials, modalities, care and system according to the patient's need. Thank you for your attention.